Good evening, everyone. I wanted to welcome you all to our wonderful webinar, Melanoma Health Checks and Monitoring tonight. I'm so glad you've been able to join us. My name is Victoria Beadle, and I'm the CEO of Melanoma Patients Australia, and will be your presenter for our evening. I'd first like to acknowledge the traditional owners of the land upon which we meet today, and elders past, present, and emerging. We want to sincerely thank our sponsors for this evening, MSD, in its support of MPA in this webinar series. We are very appreciative. MPA is a not-for-profit organisation created specifically for the support of melanoma patients and their families wherever they are in Australia. MPA's vision is creating a world where no one affected by melanoma walks alone, which is why evenings like tonight are so important, because we connect people and provide them with critical evidence-based information. If you want to find out more about MPA and our wonderful services, I encourage you to head to our website for further information. We are very privileged this evening to have 5 speakers and are very grateful for their contributions, insight and time. The Honourable Jason Clare, MP, Professor Mark Shackleton, Professor Peter Sawyer, who will be represented by Dr. Hannah Gribben in the Q&A session, and our wonderful patient speaker, Leanne Lovegrove. Firstly, we'll be recording this webinar, which will be published on our website in the next couple of weeks and in the future months as part of our new Wellness Hub. We plan to have a couple of Q&A opportunities during the evening, and at the bottom of your screens, you will find the Q&A function, which will give you the opportunity to ask questions anonymously. Our speakers will endeavour to answer these questions where we can throughout the webinar this evening. We want to warmly welcome our very first speaker, the Honourable Jason Clare MP. Jason is an Australian politician who has represented the division of Blaxland in Western Sydney since 2007 and is currently the Shadow Minister for Housing and Homelessness, Regional Services, Territories and Local Government in our federal parliament. Jason is passionate about educating people about melanoma since he was diagnosed in 2019 with malignant melanoma. We are very much looking forward to hear him speak, as he speaks very passionately about the skin check that saved his life and the importance of regular monitoring. Jason, thank you for agreeing to present this evening, and we now ask you to begin your presentation. Welcome.
Thanks, Victoria, and thank you really very much for inviting me to talk tonight and to be able to share my story with other Australians who are experiencing the challenges of being diagnosed with melanoma and everything that goes with that. I kind of feel like I'm very, very lucky because I managed to catch the melanoma that was growing on my leg very early. I took a photograph of a mole on my leg a couple of years ago just because I was subconsciously worried about it. I thought there was something there that wasn't right. And every now and again, I would look at that photograph to see whether the picture that was on my phone still represented what was on my leg. And one day I noticed that it seemed to be different, that there was a bit of a dark mark inside the mole. I guess I was always looking for all of those examples of what constitutes a melanoma. And so I self-diagnosed myself and said, I need to go and see a dermatologist and get them to have a look at it. I visited dermatologists regularly most of my adult life and always showed them that, always been told there was nothing to worry about. But this time I'd formed the view in my mind that there was something that had changed and something that I needed to satisfy myself was okay. And so I think I convinced my dermatologist to cut it out. I said, look, I'd feel much better if you could cut it off and test it and tell me that I've got nothing to worry about, that I'm being a hypochondriac. And she said, okay. She said, look, if it is what I think it is, which is fine, I'll get someone from the office to ring you and tell you that it's okay. She even told me, look, it'll cost $300. If it's a melanoma, it'll cost $500. I said, if it's a melanoma, it's the least of my worries how much this will cost. Anyway, 2 or 3 days later, a phone call came, and it was from the office, and I said, is everything okay? And they said, look, we need you to book an appointment to come and see the doctor. And I said, well, look, if you're telling me I need to come and see the doctor, that means that everything's not okay, because I was told that you would ring me and tell me if everything was fine. Can you put the doctor on the phone? It was about 3 o'clock in the afternoon. And they said, look, she's busy with patients at the moment. I'll place a message with her and ask her to call you when she's free. I got that phone call at around about 6:30 or 7 o'clock that night. And those 3 or 4 hours were the most nerve-wracking, gut-wrenching, awful moments of my life, where I knew that I had something wrong. I knew that I had something that they were worried about, but I didn't know what it was, what stage it was at. And so I did what most people do, which is start to Google everything about melanoma that I possibly could. Also going through my mind at that time was, what did it mean for the rest of my life? How long would I live? At the time, my 5-year-old boy was just over 2, and I was seriously having all of those dark thoughts about whether I would see him grow up. The phone call came through at about 6:30 or 7 o'clock, and I got told the bad news that it was melanoma, but I got told the very fortunate news that it was a stage 1 melanoma, that it had been caught early, and that what the next step would involve, which is some form of surgery to cut or excise a larger portion of skin around where the melanoma was. Because the melanoma was on my shin bone, it meant it was in an area where there wasn't a lot of loose skin. So I had to have surgery and what's called a buccal cut, I think it's called. Others will know the name better than I do. Anyway, about 50 odd stitches later, I looked like a shark had bitten me, but the cancer was gone. A safe area had been cut out, and I was told that the next step for me was just making sure that I keep an eye on my body to make sure that if another melanoma grows, that I'm onto it as quick as possible. And I guess that's the key message I took out of that, was that as somebody who's had a melanoma already, the chances are greater for me than for the ordinary Australian that there'll be another one that will grow on me at some point in the future. And so I need to be vigilant and check myself regularly, get my wife to check me, but also to go to those regular 6-monthly checkups with my doctor. That experience has also caused me to think about what can I use with my job to be able to talk about this as publicly as I can and encourage people to do what I did, which is to check yourself, take photographs of moles that you're concerned about, and to go and see your GP or see a specialist and get a skin check. I think because of that, a lot of my mates have gone and got a skin check. Plenty of them have had pieces of them cut off. Most of them have been told afterwards that everything's okay. But one experience I did want to share with you was about 12 months after I'd been diagnosed with melanoma. I was walking through Parliament, and another member of Parliament asked if I had a moment to talk to him privately, and we went into a room where nobody was, and he took his tie off and unbuttoned his shirt and showed me a large scar on his chest. And he said, "Thank you." He said, "Your story sort of triggered me to go and get a skin check, and they found a melanoma." It occurs to me that it's stories like that, all of us encouraging our friends and families and everybody that we know to get checked, given the nature of this disease in the country in which we live in, that by encouraging other people to get checked, we can help save lives. It's not just him. There are a whole bunch of different politicians that in the last couple of years have been diagnosed with melanoma. One of them is an MP from Victoria who's been diagnosed with a melanoma in her eye. Another from Queensland, Jim Chalmers, the Shadow Treasurer, also with a melanoma on his chest. Another Member of Parliament, an Indigenous Member of Parliament, who likewise has been diagnosed with a melanoma. And it just, that reminds us, if we need reminding, that this is not a disease that just affects people who've got pale Anglo-Celtic skin. It can affect everybody. And if we happen to live in regional Australia, if we happen to live in, do jobs that require us to spend a lot of time outdoors, or we spend a lot of time having fun outdoors, then it just increases the chances and the risk that, one, we get melanoma, and two, that the melanoma that we found first off could come back again, or at least another melanoma could come back. And so the importance of getting regular checks is, I guess everybody here knows that. It's a part of my daily routine now, making sure that I book in that 6-monthly check, looking for things that I think are different on my skin all the time. It's a sense of paranoia and living with it. But when I get that regular skin check, I don't get that scanxiety that some people talk about. It's actually one of the best days in the year when you get that check and the doctor tells you that everything's okay. Another story, Victoria, perhaps worth mentioning, is another friend of mine who's diagnosed with melanoma. He had a really sore neck and was rushed to emergency by his wife. They thought he had a slip disc, and it was only after they did some scans at the hospital that they found out that he had a tumour wrapped around the top of his spine, and also another one at the bottom of at the base of his spine, and another one in his liver. And he's a stage 4 melanoma patient. They still haven't found the primary mole. It's terrifying to think that you can be afflicted with melanoma and there is no way of knowing it, because there is no way of searching for a mole that you think might have changed, because it's not visible to the naked eye. But that's what happened to him. 10 years ago, if you had stage 4 melanoma, I'm told by the team at the Melanoma Institute that people were told to go home and make a will and arrange your affairs. It's a little bit different today. The work that's been done by our scientists and our specialists to find ways to keep people afflicted with melanoma from the fate that many others suffered decades ago is astounding. But one of the impacts of that is we've got to keep an eye out for more melanoma. The longer we live, the more chance that there is that another melanoma will come along. And so checking our skin regularly and getting those regular checks is so important. One of the side effects of COVID is that people haven't gone to get checks. And I'm terrified that one of the long-term implications of COVID, aside from the obvious mental health impact it's had on so many members of our community, is that so many people that should have got the checks that they desperately need, whether it's for melanoma or other types of skin cancer or other types of testing that's so important to keep an eye on their health, has been missed. And that's allowed melanomas, in our case, to sit there and grow and metastasize. So as COVID recedes, hopefully in the background, I think it's more important than ever that we send a message to our whole community. You've got to get checked. Please get a skin check. It could save your life, because I'm certain it saved mine. Thanks very much, Victoria.
Thank you so much, Jason. And, just sharing that story of how many of the other politicians have been affected in Parliament. It's really shocking, and I think, I think the fact you've been brave and shared your story with others is incredible. And the more people that we have in leadership positions like yours that are willing to share their stories and raise awareness of just how serious melanoma is incredibly important. You noted the impact of the COVID pandemic on our figures for melanoma, and interestingly, there's some new data out from Cancer Australia just in the last couple of weeks, which actually shows a 14% drop in melanoma surgeries and related procedures, and that data has been analysing Australian data during the pandemic. So it really is concerning that we have a large number of people potentially who are out there with melanomas that potentially haven't been picked up or have missed their regular checks with their doctors. Have you got any particular message to share with people, and perhaps we can use that, more broadly in our communications?
Well, that big drop in the amount of surgeries is a worrying figure. The amount of melanoma in our community hasn't dropped. The reason we've seen that drop in surgeries, no doubt, is related to COVID and Australia being locked down and fewer people going to the doctor to get skin checks. Now, I can understand why fewer people are going to the doctor because of COVID, but please, if you haven't had a regular skin check in the last 12 months, then go and get one now. We're on the eve of summer. It's the perfect time to get the message out to the community that skin checks are important, that melanoma kills, and that this is a peculiarly Australian disease in the number of Australians that it kills because of the nature of our climate and the number of people who spend time outdoors in our beautiful climate. The fact that that number has dropped tells us that there is melanoma out there that hasn't been diagnosed and that is still there on people's bodies, growing, metastasizing. The sooner you get a check, the sooner you get the melanoma cut out, the better chance you have of being able to live a long, normal, happy, fruitful life. And there's so many examples of melanoma in our community. Almost everybody knows somebody who's been affected by it. No one's immune from it, whether you've got pale skin like me or darker skin like the friend I mentioned a moment ago. So if you haven't had a check, go and get one.
That's right. That's brilliant messaging, Jason. As you say, perfect timing. We're just at the beginning of summer. We're about to head into National Skin Cancer Action Week, so we can, really raise awareness in the broader community as well as amongst our patients and their families, and remind people how important it is to keep a check on your health. And before, I know you've got to dash away, Jason, but before you leave us, you talked a little bit about just the impact of, receiving the diagnosis and how tough that was for you, and the fear that it might have spread. What do you recommend to people perhaps recently diagnosed with melanoma? Look, I know you had a stage 1 melanoma, but often it's just as stressful. It doesn't matter what stage you're diagnosed, you still go through some very similar challenges, Jason.
Yeah, I think I had more trouble dealing with the word cancer than I did with melanoma. Just the whole idea that I had cancer, the C word, I couldn't even say the word for a while. And I sort of felt myself feeling sort of trapped and unable to move, thinking, am I going to die? It was, I think the question that people ask themselves when they get told they have cancer, whatever form, it was easier to think, well, melanoma, that's something different. But as you research and understand, what type of cancer you've got, I realized I had one of the most serious and deadly cancers that you can get. And so the anxiety gets worse, the fear gets worse. You try to work out, and I was doing all of this without knowing whether I had stage 1, 2, 3, or 4. All I knew was that I was probably going to get a phone call telling me that I had melanoma. So it wasn't a great period of time. But even after I got told, look, it's stage 1, you've got it early, all of these things are good, it's this level, I found myself sort of digging ever deeper, trying to learn more about what that meant. And for some people, you can do that on your own. I certainly felt that I needed the support of my wife and my mum and dad, and they were able to help me an awful lot. I didn't know that melanoma patients, that your group, I didn't know they existed at the time. And if I'd known that Melanoma Patients Australia was there when this happened to me, I would have reached out to you, because it would have helped me enormously. And I'm being interrupted by this little guy at the moment. This little guy, this is Jack.
Hi, Jack.
Say hello. Good boy. Jack's 5. He's just turned 5. And I mentioned earlier that when you get a diagnosis like that, it's this that's on your mind.
It has a huge impact on not just you as an individual, but the whole family, Jason, doesn't it?
Yeah, it certainly does.
We had a question from the audience really quickly. I know you're really short on time, but there was just a question around how you talked about having to convince your dermatologist to cut your mole out. You were concerned about it, but it's often quite hard. We have patients to find a dermatologist who's happy to do a biopsy. What did you obviously knew something was wrong and really persisted in getting the answers that you needed.
Yeah, it's not the sort of thing that I really. Yeah, see you, mate. See you. It's not the sort of thing that I talk about when I do TV interviews, because I don't want to criticize the dermatologist. But if I'm giving you the honest story, this is it. And I often think how difficult it is to make that decision as a medical practitioner about whether you cut or not, because they're hard things to be able to determine. I've had 2 or 3 bits cut off me since the melanoma, and I've got a new dermatologist now, by the way. But he'll often ring and say, "Look, the good news is it's not melanoma. The bad news is, sorry, that we chopped it off." And my message to Chris, my dermatologist, is keep cutting. I remember getting something cut off my back when I was in my 20s, and it wasn't melanoma, and I thought, oh, that's just a butcher's surgery. They're just trying to make money out of cutting bits off me. My whole view on this has changed now. That there's only one way to be certain it's not melanoma, and that's to do the pathology, to do the biopsy. And so I say to my dermatologist, look, I'm a melanoma survivor. The chances are there's another melanoma on the way. If we find anything we're worried about, then cut it out and test it. But it's a difficult job to be able to determine what to cut, which is why I asked the question to experts in this area. Is this a specialized thing that only some medical practitioners are really good at? Should we be telling people to go to GPs when you really need to be a specialist in your field to know what you're looking for? And the response from people like the Melanoma Institute is that the only way to make sure that every Australian who needs to get a skin check gets a skin check is to skill up GPs, because there aren't enough specialist dermatologists to be able to get the job done. And so that's probably part of it as well, Victoria, is making sure that our GPs, there's a multitude of things that they need to be able to look out for, but this is a big one. And I just make the point again, when I went and saw my GP and said, look, you should know I'm dealing with melanoma, she said, well, I've got a number of patients who are in the same boat. And then went on to tell me the story. I live in Bankstown here in Western Sydney, very multicultural community. And her list of patients with melanoma included people from India, people from Africa, people from Asia. It's not the stereotypical, pale vampire-looking bloke from Bankstown.
Very true. Melanoma can affect so many people, and raising awareness like we are this evening, Jason, is incredibly important. I think a lot of our patients in our groups say these words, if in doubt, cut it out. If the patient's concerned about a mole or spot, then and also be an advocate for yourself. If you're concerned and you're not getting the answers that you want or need, you've got to keep following up. Often patients find.
I think that's right. Doctors aren't perfect. Doctors aren't always right. And maybe there's something in my story that will encourage people to get a second opinion. Press the doctor if you don't think you're getting the answer that you want. Because in my case, if I'd left it to my original dermatologist, it would still be there.
Right. Well, look, Jason, we are incredibly grateful for the time you've given us this evening. We know you've got a beautiful family to tuck in bed tonight by the looks of things. So we wish you well with the new baby and your beautiful family. Thank you for raising awareness. We will be sharing this very widely, and appreciate your willingness to share your story this evening with many of our patients and families across the country.
Oh, thank you, Victoria. Thanks for the opportunity. And if there are other melanoma patients and survivors around the country that want to reach out to me personally to tell me their stories, or if there's something that I can do that you think, using my role as a member of Parliament, can help you, then please don't hesitate to give me a call or send me an email or reach out to my office.
That's wonderful. Thank you. Thank you, Jason. Good night.
Thanks, everyone. Bye-bye.
Thanks, everybody. Right, we will move on to our second speaker. I'm sure you'll agree it was wonderful to have one of our federal parliamentarians sharing a personal melanoma journey story with us tonight. And we might move on now to our more clinical focus for the evening, and we'd like to welcome Professor Peter Sawyer, who has pre-recorded his talk for us this evening, but is represented here by Dr. Hannah Gribben. So a very warm welcome, Hannah. Professor Sawyer is the Director of Dermatology, Director of the Dermatology Research Centre at the University of Queensland at the Dementia Institute and the PA Hospital Dermatology Department. He leads the NH&MRC Centre of Research Excellence for the study of NEVI and the ACRF, which is the Australian Centre of Excellence in Melanoma Imaging and Diagnosis. He has an MRFF practitioner fellowship and is a fellow of the Australian Academy of Health and Medical Sciences. We're very delighted to have Peter speak with us this evening, and also for Dr. Gribben to be here to answer questions. So we'd like to invite you now to introduce yourself and presentation.
Thanks very much, Victoria, and good evening to everyone who's logged in tonight, and thank you for your time. As Victoria mentioned, I work with Professor Peter Sawyer at the Dermatology Research Centre at the University of Queensland, and one of my passions is early detection of melanoma, as well as supporting and educating melanoma patients. And so this evening, our presentation does focus on some background information for melanoma patients, and then as well what surveillance and what to do after having your melanoma diagnosed. So I will just share our presentation now.
Good evening, everyone. My name is Peter Sawyer, and I like to thank Victoria for inviting me to give this talk today. Unfortunately, I will not be able to be with you personally on the Zoom, but Hannah Gribben, who is her, we prepared this lecture together. Hannah will then be available for any questions. First of all, I'd just like to share my conflicts of interest in this space. And I have structured the talk about skin check for melanoma patients around 4 topics: melanoma in Australia, melanoma, why and how, after melanoma diagnosis, the skin surveillance, and a few words about skin self-examination. As you probably know, Australia and New Zealand both are leading the world in regards to incidence of melanoma, and Queensland has even been dubbed the melanoma capital of the world. And you all have a bit of an idea of the numbers. It's certainly, melanoma is a big issue in Australia, and it's the most common cancer in Australian age between 15 and 39. I'd like to share now with you my thoughts, a few thoughts about why and how melanoma. And unfortunately, we never know why one person gets a melanoma or not, or any other cancer. It's usually a combination between the environmental risk and the genetic risk. And there are persons with a low genetic risk where there are more sun, UV is required, and we like to call it then the low nevus, low mole and high sunlight pathway. And on the other hand is a high nevus, high mole and the low sunlight pathway. So it's a combination of genetics and environmental causes. And just to share with you one example of the low nevus, high sunlight pathway, a gentleman who has obviously spent quite a few years in the sun. He doesn't have too many classical moles from our point of view. They're sun-induced freckles, and then a very early melanoma. On the other hand, this gentleman has several moles. You see some of them are actually quite large, and this person had on the chest a significant advanced melanoma, which is so graphic that, to be honest, I don't like to share it. But I think the difference is quite clear that this person has many moles. And just to share with you another example of a gentleman who has many large moles. He has a bit of sun damage, but not too much. And I think what I like to reiterate is that the risk of developing a second primary melanoma is approximately 10%. And the risk is highest in the first years after the first melanoma diagnosis, but still it's a lifelong risk. And probably the most relevant risk factor for melanoma, particularly in younger persons, is the number of moles. And many melanomas arise next or within existing moles. Having said this, routine excision of non-suspicious moles doesn't reduce the risk of future melanoma. If we now see a person with many moles, usually we take a dermatoscope in the hand, you know, these handheld systems with a specific loop, and then we are basically looking at many moles and look at the dermoscopic features. And every so often, when one lesion is sticking out, there's a so-called ugly duckling phenomenon, then this is the one which is potentially a melanoma, and it's then will be excised. So understanding the melanoma risk, I've spoken quite a bit about moles or nevi, but there is of course the skin color, the hair color, the eye color, the degree of freckling. These are all risk factors, and in the Caucasian population in Australia, there are about 6–7% of people who have red hair and blue eyes, and these persons are on a higher risk for basal cell carcinomas and squamous cell carcinomas, but also for melanoma. And on top of it is often then a history of sunburn. And there's also a well-known familial risk for melanoma. So person with a familial, for another family member, first-degree family member having melanomas have a twofold increased risk for melanoma. So I like to talk now a little bit about what happens after the melanoma diagnosis in regard to skin surveillance. And please note, I'm not focusing now from an oncologic point of view for medical imaging. I just focus on skin surveillance. And obviously, you know that there are different stages from melanoma. What you will have heard, level 1 melanoma or melanoma in situ. This is basically what we call a stage 0. The tumor is confined to the epidermis, and there is no risk for advancement, for getting, for progressing. But then depending how deep the melanoma is going into the tissue, then we have the different stages, stage 1 and stage 2. And if there is a lymph node involvement, we call it stage 3. And when there is involvement other parts of the skin or the liver, lung, and other organs, then this is a stage 4 advanced melanoma. And you know that we have exciting new treatments available, immunotherapy, targeted treatment. And so nowadays, luckily enough, we have quite a few opportunities. Having said this, I like to focus on the skin surveillance of a person who have had a melanoma and have a high risk of melanoma. So again, full skin examination, skin self-examinations, and then a few words about skin surveillance adjuncts. In regard to the full skin examination, what to expect, and I'm sure many of you have witnessed this, is a top to toe check, undress to underwear, and the skin underneath, and also the skin underneath will need to be checked. A dermatoscope, as you have already seen, for lesion magnification, and clinical photos and dermatoscopic photos will be done for the record and for basically seeing also if there's any growth of the lesion. We will also do always a lymph node examination of the regional lymph nodes. We will also have a close look at the melanoma scars or other scars of lesions where a tumor has been excised. And of course, we always will ask, are there lesions you are concerned about? And we will have a specific close look on those. So how often, then, is a very relevant question. There are no specific guidelines, but more frequently, if there's a history of melanoma, I think it's fair to say between 3 and 6 months, particularly for the first 5 years. But many colleagues also have a pragmatic approach, like myself, that they say, let's see you every 4 months. So there are no general rules about this, but please discuss this with your doctor. And there are slight differences about the opinion here, but at the end of the day, the more, the better. And obviously, this is based on your individual risk factors and the nature of your particular of your moles, number, size, and appearance of your moles. It's also, I think, the skin examination should be done by your GP, your skin cancer specialist, but and your dermatologist. But it is quite interesting to know that, at least in Australia, most melanomas are detected outside the doctor's office. Up to 50–60% are self-detected, and about 10–15% of the partner. And I'm pretty sure that you will have some thoughts about this, but this is pretty relevant data. In regard to skin self-examination, a few words. This is something which we are recommending quite strongly, and I like to share with you Professor Monica Janda, who has recently underdone a randomized control trial in this field, where basically we looked at a group of persons who did do the skin self-examination, self-skin examination based on her, based on the instructions we gave them, and the second group had mobile phones with dermoscopy attachment, and so naked eye versus mobile phone technology. And interestingly enough, both groups had overall high levels of performance in finding potentially suspicious spots and moles. So our conclusion was phoning it in is not always the answer for skin cancer detection. Having said this, these apps are getting better and better, and in the years to come, they will certainly have a significant input. In regard to the skin self-examination, I think it's a very good idea to ask family members or close friends to look at hard to see areas the back, the scalp, as here in this image behind the ear, the soles of the feet. Just to share with you, melanomas on the scalp, or for example, the soles of the feet, on the heel, are very, very rare, and therefore often also not so easy to be detected. So it is important that you look also on all sides, and don't forget between the fingers and toes, genitals and buttocks. And it's also always a good idea to look at them, that you look at your melanoma scars and the surrounding skin, and it's also a good idea if you feel the draining lymph nodes from your melanoma sites. But please don't do it every day 5 times. Do it once every 3-4 weeks, because if you do it constantly, you will also irritate the lymph nodes. And I don't think that this might be very, very helpful. I'm pretty sure that you will already have heard and known that there are very common sites for melanoma, and for the men it's the back, for women the upper arms, the outside of the upper arms, and the lower legs, and in general in Australians after certain age bracket, very common on head and neck, obviously because of the expression of the sun exposure. And again, just to show you, this is a back of a young man who had a melanoma, but also several moles excised. And you see this person doesn't have too much sun damage. And also here, this is a lady who had a skin-colored lesion, what we call an amelanotic melanoma on her lower leg. And as you can see, no sun damage at all. So it is, skin self-examination is certainly very important. And you will also have heard about the ABCDE rule. From my point of view, A and C are the most important aspects, you know, the asymmetry and multiple colors. And I think whenever you have the impression that the lesion is really clearly asymmetric, the different colors, then by all means, go to your doctor. Having said this, there are, of course, exceptions of the rule, as you have seen here in this lesion here on the lower leg. This is not asymmetric at all, and also not multiple colors. So while most melanomas can be diagnosed quite well based on clinical features, it's sometimes not so easy even for the experienced doctor. And this is something which is simply a reality. I think it's also always very important to look at the scars. And just as a general rule, whenever you have a pigmentation within a scar, please discuss it with the colleague who did the surgery, and or check it with your GP. Because if you have a pigmentation in the scar, it could be, of course, a recurrent melanoma. We see actually quite common also a recurrence of benign moles, which we call then a recurrent nevus, a recurrent mole. And this is a very specific phenomenon, which is completely harmless, and we call it pigmented streak in the scar, which in certain persons we see in all sorts of scars. But please don't be a hero yourself. Whenever you see a pigmentation in the scar, just share it with your doctor. I'm coming to the end of my talk, and just like to say a few words about skin surveillance adjuncts. And in this context, I like to mention our ACIF, Australian Cancer Research Foundation, infrastructure grant, which UQ, but in Sydney and Monash, we got it all together. There are 15 3D total body imaging systems across the eastern seaboards. And these images capture nearly the entire skin surface in a 3D image. Of course, not the scalp, and also doesn't see on the underwear, and of course not on the your soles. but the images, as you can see, have a pretty good quality, and obviously opens up the door for telemedicine, but also for artificial intelligence. But please know, this is at the moment just a research project, and there's still quite a bit of research needs to be done. And just to share with you how this system looks a little bit like a spaceship. These 92 cameras are firing within a second, and then the 3D total body avatar is built up, and then we can do in addition individual demoscopic images. So I'm actually at the end of my talk, and this is an EVOS who has a shape of a double heart, if you like to see it. And yeah, thank you so much for your attention, and please ask your questions to Hannah, and have a nice evening. Thank you.
Thanks to Professor Sawyer for an insightful presentation, and to Dr. Gribben here for assisting in the preparation of it. I thought it might be great if we perhaps asked a couple of questions. I think a number of our patients and their families are very, very interested in the final part of Professor Sawyer's talk around the ACEMID Vectra machine trial, the 3D total body imaging. I wonder if you could tell us a little bit more about that, Dr. Gribben, and you know, how do people get involved? What are the requirements to get involved in that particular program?
Yeah, sure. So ACEMID has been active and running in Brisbane since February this year. So at the Dermatology Research Centre at the University of Queensland, we were the first site, and we are still recruiting. And it has been launched at the other sites in Melbourne and Sydney as well. So simply Googling the study, it should bring up some information and some contacts to register your interest. It is quite a broad study. So we're looking for many participants with all different skin kind of history backgrounds. So we obviously are very interested in patients that have had melanomas and the role that this could play in their surveillance, but also for people who have never had a melanoma or other skin cancer, they're also welcome to join the study. So it is for participants over the age of 18, but otherwise there's no specific skin cancer history required. And the difference that a skin cancer history or a history of melanoma will make will be how frequently you're seen as part of the study.
That's great, Dr. Gribben. And it sort of leads into one of the questions that one of our participants tonight has asked. One of the participants asked, my husband has a mole that to me looks very suspicious. So I've taken a photograph of it on my phone to watch. And the GP has said it's fine. We don't have an available dermatologist in our region, you know, or potentially access to one of the wonderful Vectra machines. Is there another option for someone to review, or should they just go back to the GP?
Yeah, so it is difficult in particular areas, of course, to access specialist services and then to travel for something like the Vectra imaging. So in the cases of a specific lesion that you remain concerned about, we certainly recommend getting another review with the doctor. And I think you've definitely done the right thing, which is to take that baseline photograph of it, and that can be used for comparison as well. Again, you know, it sounds like the particular doctor wasn't necessarily worried, but we always think if you remain concerned, don't, you know, hesitate to get a second opinion. And also, you know, it's a completely reasonable question as well to ask your doctor how experienced they are with recognizing and treating melanoma, and if perhaps they feel they haven't had a lot of experience, or they have a colleague that has a special interest in skin cancer or melanoma diagnosis, that perhaps they could recommend someone to get that second opinion from as well.
That's great advice, Dr. Gribben. And one of our patients has asked another question about artificial intelligence versus dermoscopy. Is one better than the other? What a great question.
Yeah, so artificial intelligence is very much an area in progress for melanoma detection or monitoring of moles or other skin lesions. And it's certainly something that in the future will inevitably become part of skin checks and monitoring moles. At the moment, there aren't really any specific artificial intelligence systems that are in routine clinical practice. And, you know, as we see it going forward in the future, and this is certainly something that the vector imaging and the photographs taken through the vector imaging system will contribute to, and that'll be, you know, teaching the artificial intelligence about moles and about melanomas and what features are important. So it certainly won't be a dermoscopy versus artificial intelligence. It'll be a conjoined and complementary process of having your skin check with your regular doctor, having them photograph specific lesions that they've flagged for monitoring, and then using those photographs with the doctor's assessment, as well as artificial intelligence as it develops and as it improves, to get an overall assessment of the risk of that lesion. And so over time, it will certainly become something that we see being part of monitoring for moles and detection of melanoma. At the moment, it's not necessarily routinely used. And so dermoscopy for the assessment of lesions is the gold standard and is something that you should expect to be done during a full skin check with your doctor.
Great, thanks for clarifying that, Dr. Gribben. The next question is from one of our patients who said, what is the likelihood of getting more melanomas after you've had one? I've had 3, the last being amelanotic. So I'm just wondering if you could perhaps, I think Professor Sawyer did touch on this in his presentation, but maybe you could give us some of the stats and figures around that.
Yes, so as Professor Sawyer indicated in his presentation, having had a melanoma does increase your risk of having a second melanoma diagnosed. And we see that as sort of the biggest or the most significant risk factor for patients is a previous history of melanoma. And the statistic that we have from all the studies is that having had one melanoma, your chance of having another throughout your lifetime is 10%. And that risk doesn't necessarily go down at all. It remains high throughout your lifetime. As Professor Sawyer said, it is in those initial years after your first diagnosis that we do see the second or third, etc. melanomas being diagnosed more. And whether that's because of now you're on this track of regular surveillance and having lesions detected, then perhaps that contributes. But we do, you know, still consider that initial 1 to 2 years and up to 5 years after your first diagnosis as a higher risk period. And so the importance of having skin checks with your doctor and also doing your own skin checks yourself or with the help of a family member or friend is, you know, extremely important, especially in that time frame. And it sounds as though that patient mentioned their amelanotic melanoma, and that's you know, a lesion that is a little bit different to some of the melanomas you might commonly see in, you know, educational posters where it's these dark lesions with lots of brown or black or blue. These amelanotic melanomas don't have that pigment, and so they seem more skin colored or pink. The difference with that is because we don't have that pigment, we don't, on the dermoscopy examination, some of the features that you usually expect to see in a melanoma aren't necessarily there because we don't have the brown color, etc. And so they are historically more difficult to diagnose, but yeah, I think that just highlights that, you know, melanomas come in all shapes, sizes, colors, etc. And that's why, you know, it's really, really important to have those regular checks, because not all of them look like your typical image that you might see on websites, etc. So having your doctor that's experienced with skin examination is extremely important, in particular for those harder to diagnose melanomas.
Thank you. And that is a really a difficult one. And I think a lot of a lot of awareness needs to be raised around the fact that not all melanomas look the same, and that if you are concerned, you really need to seek that medical care. They can be very pale and sometimes blue, sometimes pink. Then they're not always the same looking brown, dark moles as we see in many of the pictures. So very good point to make. Thank you very much. One last question, a little controversial. What is the preferred or recommended biopsy for a suspected melanoma, and when should a shave biopsy be used?
So when it comes to biopsying a lesion that's suspicious for melanoma, there isn't necessarily an exact right answer for every lesion, because, you know, every spot is different. And, you know, depending on the type of lesion, certain biopsies are appropriate. So while you will often hear that the recommended biopsy for a melanoma is the excisional biopsy, so having it cut out and having this, you know, the defect then stitched up, that has been considered the gold standard. But we do see shave biopsy being used quite commonly and safely, and that's for those lesions that are flat, that perhaps your doctor doesn't have a super high suspicion for melanoma, but they do want to get that histological diagnosis. A shave biopsy is appropriate, and particularly for areas like the face, and that's really relevant in Australia, where we do see a lot of flat melanomas on the face. It can be, you know, quite a big procedure to have an excisional biopsy on the face, and then if that lesion doesn't come back as a melanoma and you're left with a sizable scar, you know, it really begs the question of, is a different biopsy more appropriate? And for those flat lesions, particularly on the face, a shave biopsy is appropriate, and it is used, you know, quite regularly. But of course, it will, you know, always depend on the assessment from your doctor. And so you can always discuss that with your doctor as well, as to, you know, what they think the lesion might be and what kind of biopsy they're intending to do, and sort of their decision-making process around that. When it comes to, you know, biopsies, one thing we do certainly say is that for your raised lesions or, you know, nodular lesions that are suspicious for a melanoma, we wouldn't want you to have a shave biopsy, just because with those raised lesions, it tells us that they're a bit thicker. And so if you imagine trying to shave underneath that, you're likely to leave a bit of the base behind. So those are the lesions where we would certainly say an excisional biopsy, where you can cut into the skin and ensure that you get the entirety of the lesion. That's appropriate. But again, with your flat lesions, particularly in sensitive areas that, you know, having a scar is quite difficult, a shave biopsy can be appropriate. And yeah, always discuss with your doctor if you're unsure as to, you know, why they've decided on one versus the other.
Thank you so much, Dr. Ribben. On behalf of MPA, I'd like to say a very big thank you to both you and Professor Sawyer for your presentation and great questions this evening. And thank you very much for being involved.
Thank you. Thanks, Victoria.
Thank you. I just wanted to bring your attention now to a short survey which has been designed by Professor Monica Janda, which is seeking people willing to share their views about this new technology. So we've talked about this evening the Vectra machine, 3D total body imaging. So they are looking for people to share their story, their views about the technology, which then could help early detection of skin cancer. So if you'd like to get involved in this survey, we'll be sending you a link at the end of the webinar, and would really appreciate it. And the researchers at the universities listed there on the slide would be very delighted if you took the time to fill the survey in. Thank you. So now I'd like to introduce our next speaker to you, who is Professor Mark Shackleton. Professor Shackleton is the Director of Oncology at Alfred Health, a Professor of Oncology at Monash University, a Victorian Cancer Agency Clinical Research Fellow and Chair of Melanoma and Skin Cancer Trials. After training in medical oncology and at the Ludwig Institute in Melbourne, Professor Shackleton undertook PhD studies at the Walter and Eliza Hall Institute of Medical Research and postdoctoral work at the University of Michigan in the US. He's received several major prizes for his research, including the 2006 Victorians Premiers Award for Medical Research, a 2010 NH&MRC Achievement Award, 2011 Pfizer Australia Fellowship, and a 2016 Victorian Cancer Agency Clinical Research Fellowship. In 2012, he was awarded the Australian Science Minister's Prize for Life Scientist of the Year. We are absolutely delighted to welcome Professor Shackleton to speak to us this evening.
Hi, Victoria, and hi, everyone. Thanks very much for taking the time to listen to me this evening. So I'll just jump to my shared screen here and start there and then there. How's that? Is that okay? No.
Perfect.
Message that it's not great. Okay, you can see it. Good. Yeah, so thanks so much for the invitation to come and talk to you guys tonight. I was asked to talk about more advanced stages of melanoma than what we just heard about in the previous talks. So those stages that we call stage 3 and stage 4 melanoma, and I will sort of discuss and describe the definitions of stage 3 and stage 4 in a moment. So the first thing to say, so cancer staging generally is a very commonly used tool done by all sorts of different cancer specialists, surgeons, radiation specialists, medical oncologists like me. And it's important because the stage of a cancer essentially defines or describes the degree to which it's spread and grown from the point of its beginning, from the point of its origin. So for most cancers, stage 1 and 2 describe stages where the cancer is still in the same place where it started in the body. So that's from, in the case of melanoma, most often on the skin, and wherein there's no evidence of spread to other parts of the body beyond that tissue of origin, if you like. So that's stages 1 and 2. Stages 3 and 4 refer to cancers that have actually spread, so they've moved away, spread away from the area, from the tissue of origin, the place where they actually begun, and moved to other parts of the body. That's a process which is called metastasis. And I'm going to show you the key, or explain now the key differences in the patterns of metastasis in stage 3 versus stage 4 melanoma. And in fact, the same concept that I'm describing to you for melanoma actually applies to pretty much all cancers. So stage 3 spread or stage 3 cancer means that a cancer has traveled, that some cells from the cancer are broken away and have started to spread and travel, because cancers do have the ability, some of the cells to move in some instances, and they can certainly enter other structures. And in stage 3, the cells have entered these vascular structures, sort of vessels within in the case of melanoma, in the skin, which are called lymphatic vessels. So our bodies are full of lymphatic vessels. They're everywhere. They're the ways in which fluid comes out of the bloodstream and sort of seeps into the tissues normally in our normal functioning. It's the way that fluid is basically brought back into the bloodstream via a series of very complex vessels. That fluid itself is called lymph, and those vessels are called lymphatic channels or lymphatic vessels. And so in the case of stage 3 spread, the idea is that in this case the melanoma cells essentially invade into the local lymphatic channels or lymphatic vessels around that area, and then essentially get carried along by that lymph fluid in those vessels. And one of the key anatomical structures that they encounter and into which those vessels drain are structures which are called lymph nodes. So these are usually quite small, solid sort of nests of tissue that are full of actually full of immune cells mostly. So they're very important parts of our immune system. And lymph fluid, and in this case, lymph fluid containing cancer cells in a stage 3 spreading melanoma, enter those vessels and basically go into the lymph node, which carried along by the fluid. So any melanoma that enters those vessels, and sometimes the melanomas can stick as they're traveling on the vessels and start to grow and form lumps sort of halfway along, and that's sometimes called in transit disease, or where the cells have actually got to those first few sort of draining lymph nodes that are encountered in the passage as the lymph passages through those channels. That whole process of metastasis into those structures essentially defines stage 3 melanoma spread. And this is an example of a melanoma in front of the ear here, which has spread to this now swollen lymph gland just under the ear here, which is an example of if you like, a stage 3 spread. So spread of cancer cells just within the nearby lymphatic system. So that's quite different concept to stage 4 melanoma, which, although it also describes spread of cells and invasion of cells into vessels, in this case, the key distinction is that the cells are inside the bloodstream. So not just inside the lymph, but also, or sometimes instead of, present in the actual bloodstream. And we know that cancer cells can in fact invade directly into the blood system, or sometimes they can find their way there via tracking through the lymphatic system that I just described. So a cancer can start off as a stage 3 lymph system spreading cancer, but then keep tracking in the lymph system, following the fluid all the way until it ultimately makes its way back into the bloodstream. And once the cancer cells are present in the bloodstream, they can essentially travel around to any part of the body. And that really is the fundamental defining feature of stage 4 cancer, and in this case, stage 4 melanoma. And you can see the sort of devastation that this sometimes creates for people. In the top here, evidence of spread of these cells that have then deposited in the brain and form lumps, which are these white structures here. Or on the scan here below, which is something called a PET scan, you can see where these sort of black areas here indicate where the melanoma has spread here into, these are probably lymph glands in the neck, but here are spots in the lungs, and this will be a lot of melanoma infiltrating into the liver. So that's collectively called stage 4 disease, melanoma that has spread into the blood system and traveled to other parts of the body. So I'll focus first on stage 3 melanoma and I guess briefly overview its treatment. So stage 3 is actually quite complex, and it's divided into 4 different subtypes nowadays. And essentially, I won't go into the details of those, but they're essentially defined by the degree of lymph spread. So where there's only a very small amount of spread, that's called stage 3A. Where there's a very large number of cells that are spread, usually to many different lymph glands, that goes all the way through to stage 3D. For pretty much all stage 3 melanoma, the mainstay of treatment is actually surgical removal of those lymphatic structures. For 3A, the surgery is usually pretty minimal, and the surgeon just removes what's called the first draining lymph glands. For more advanced stage 3, so B to D, the surgery is usually more extensive, and the surgeon tries to remove all of the lymph glands that are in that sort of local affected region, actually whether he or she knows that melanoma is actually in all of those glands. They still endeavor to remove as many of them as possible, because we know likely that if one is involved with a large amount of melanoma, then there's likely to be other lymph glands involved also. Of course, the main risks of that sort of surgery, particularly particularly or of any surgery that removes part of the lymphatic system, particularly from limbs, in the groin, or under the arm, is of this condition which is called lymphedema, which is essentially chronic swelling of the limb that is related to that area where the lymph glands have been moved. It's pretty uncommon in people with stage 3A disease that just have these very small first lymph glands removed, but overall more common where more extensive surgery is performed, such as in stage 3 beta D patients. And overall, the risks are again increased if it's thought necessary for the region to receive radiation treatment after the planned surgery. These days, of course, with the advent of new anti-melanoma therapies, which I'll go into more in a moment, it's quite common that after surgery, extra treatment with medications is recommended. And this is typically for an overall duration of 12 months, although it's fair to say we actually don't know what the optimal duration of extra treatment after surgery with drugs is yet. But all the clinical trials, or most of the clinical trials that have been done, have treated people for 12 months after surgery. The two main forms of extra treatment after stage 3 surgery are immunotherapy, which are medicines that can boost the person's immune response to help it fight against their cancer. This is typically given by injections once every 3 to 4 weeks. The other type of therapies that are used to treat as extra treatment after surgery to reduce the risks of recurrence and increase cure rates are collectively called targeted therapies. These are a lot easier to give because they're given as tablets rather than by a drip, although a person needs to take them every day. And the combination of targeted therapies that we use are collectively called BRAF and MEK inhibitors. And this is why this graph here really indicates why we give these therapies. And it's fair to say that one of the greatest advances in, I think, all of cancer treatment really has been in the field of stage 3 and also stage 4 melanoma. But particularly in the last years, in the last probably 5 or 6 years, with clinical trials that have tried these drug-based therapies on patients with stage 3 disease, and are identifying that such treatment can substantially reduce the risk of recurrence. So in this graph, this is essentially generated from data that was produced via what's called a clinical trial. In this trial, there were a large number of patients that received one of 2 therapies after their surgery for stage 3 disease. In this case, this was treatment with immunotherapy, and you can see that this bottom curve describes the time after the treatment where patients developed recurrence or relapse disease, and you can see that the patients on this along this bottom line were more likely to develop recurrent disease compared to the patients on the top line that were treated with one of our newer immunotherapy drugs. So this shows that that particular drug reduces the chance of recurrence actually quite substantially. The same thing also occurs. So that was a study that tested different types of immunotherapy. This is a study that had a very similar design that tested the effects of giving patients targeted therapies after their surgery, again, to see if those targeted therapies could reduce the risk of subsequent recurrence. And you can see, again, these lines are well separated. The patients that didn't receive any targeted therapies relapsed at a fairly appreciable rate. Those that did receive the targeted therapies, in this case, these are the ones here called dabrafenib and trametinib, had much lower rates of recurrence of their melanoma. And so these are the reasons, or really the data from these clinical trials are the reasons why extra treatment after surgery with drugs is now very commonly applied to patients that have got stage 3 melanoma. In terms of monitoring patients with stage 3 disease when they're having their treatment, really there are 2 main things that we do. Really the most important thing from our point of view is to focus on looking after the person who's having the treatment and make sure that they don't get side effects, or if they do get side effects, that these are recognized early and that we can intervene and do something about them. And for that, we just perform regular checkups as well as regular blood tests. particularly those that monitor the function of the liver, kidney, and various hormone systems. We also, during stage 3 treatment, actually monitor for the possibility of melanoma recurrence, which unfortunately and thankfully relatively uncommonly can even occur sometimes during the treatment, in which case the treatment is obviously not working. For this sort of monitoring to see whether the melanoma is coming back, we again perform physical checkups, but also start to introduce different types of scans depending on the areas of the body that we're most concerned about. For the whole body, we typically use PET or sometimes CT scans, and these are usually performed roughly every 6 months or so, sometimes a little more frequently depending on the case. For patients in which we're concerned about the possibility of spread to the brain, which certainly can be very serious, we typically would do special brain scans, usually with a scan called an MRI, or sometimes just with a CT scan, again, roughly every 6 months during the course of treatment. Of course, after patients have finished treatment, which, as I said before, typically goes for about 12 months, we actually still need to watch for side effects, and I'll allude to that in a moment. You might be surprised to hear that side effects from some of our treatments, particularly immunotherapy, can actually arise after patients have stopped treatment. But the main really role of ongoing review and checkups after treatment for stage 3 disease is really monitoring for the possibility that the melanoma might come back despite the extra drug treatment that they've had. And again, this sort of monitoring comprises the same sorts of interventions that I talked about before: physicals, PET scans, as well as brain scans, typically done every 6 months for the first couple of years, and usually then annually afterwards, maybe out to 5 years or so. But we actually don't really know what the best mix and frequency of scans is in order to maximize the chance of detecting a recurrence, so we can come in with additional treatment at a relatively early stage, versus balancing against some of the risks of scans, which we can maybe talk about a little bit later. So moving down to stage 4, the first thing we do in a patient that we think has stage 4 disease is to actually find out really where the melanoma has spread to. This is also called like a type of staging. We basically want to know exactly which organ's involved, because there are some specific types of spread of melanoma that sometimes influence the treatments that we recommend. But again, it's the same series of evaluations to figure out where the melanoma is spread to: physicals, PET or CT scans, as well as those brain scans. Once we know where the melanoma is, then we think about what sort of treatment that we could offer to the patient. Even in patients with stage 4 disease, where there's only a very small number, or maybe even just one tumor that happens to have spread to another part of the body, and particularly if that tumor is causing some sort of distressing symptom, like, I know it's in a sore spot or near a bone or nerve or something like that, then sometimes we can actually still use surgery to cut out that particularly problematic tumor. And if surgery is not possible, which is often the case in these situations, then radiation therapy can actually be a very effective treatment modality to control specific individual sites or specific individual tumors. And very, very occasionally, that's sometimes all that is needed. Certainly in the old days, when we had far more limited drug therapies, patients frequently had surgery for their melanoma recurrences and then were just watched very, very carefully. And in a small fraction of patients, it was actually a pretty effective approach. Having said that, for the vast majority of patients, unfortunately, the appearance even just of one spot can often be a tip of the iceberg phenomenon, and really the only therapy that deals with melanomas that recur in multiple different parts of the body is really drug-based therapy with the medicines that I've just described. And so these include, for stage 4 disease, particularly immunotherapy, I think, is increasingly becoming the commonest sort of first-line treatment. And of course, these days there are an increasing number of different types of immunotherapy. Most commonly applied are what we call either single-agent immunotherapies, with agents which are called anti-PD-1 agents. But increasingly, there's use of what's called combination immunotherapy, which is adding to the anti-PD-1 therapy another type of immunotherapy, which is called anti-CTLA-4 therapy. And often, as I said, increasingly we're combining these these different immunotherapy treatments together. But if immunotherapy treatments don't work very well, and if the patient has a suitable molecular subtype of melanoma, then targeted therapies can be quite useful for controlling stage 4 disease in those patients. And of course, we're always interested in enrolling patients in clinical trials, and most of the major centres will have a pretty constant, active clinical trial program that will offer patients access to some of the newer types of therapies coming through. I put chemotherapy in brackets there because although that's pretty much all we had to offer people in the old days, and occasionally it actually worked quite well, it really wasn't great treatment for the vast majority of patients and has substantially been surpassed now by the newer treatments that we have. The treatment durations for people on immunotherapy particularly, but also targeted therapies, can actually go for quite a long time, sometimes even many years. And this graph, I think, here nicely describes the kind of progress of the kind of advances in the development of melanoma therapies over the last 10 years or so. So each of these individual lines describes what's called the overall survival, which is the chance that a person who received that treatment in this particular trial was alive at that given time point after commencing the treatment. And the different lines describe basically the best results from those different trials. So you can see that some of these trials down the bottom here, which describe some of the targeted therapy trials, were certainly better than having no treatment at all, in fact, massively better, but have generally more recently, particularly with some of the newer combination immunotherapy approaches, now we can sort of look back and say that those treatment options on average didn't perform as well as the immunotherapy treatments in the context of first-line treatment use. And that's one of the reasons why increasingly immunotherapy is really applied as the kind of first-line treatment in patients with stage 4 disease. So during treatment, the sort of monitoring that we do in patients receiving drug-based therapy is really very closely watching for side effects. And the sorts of things that we, the ways we do that with physicals and blood testing is pretty similar to how we monitor patients that have got stage 3 disease. But there is a really heightened awareness for watching patients very closely, particularly that are having combination immunotherapy, where the risks of side effects can actually be quite high. And some of the side effects, in fact, very serious. Of course, the other element to monitoring during treatment is working out whether the treatment is actually working against the melanoma. Again, we do this in the ways that I've described with physicals, with some sort of scans, usually PET or CT scans to look at different parts of the body, and also where it's appropriate, monitoring the brain with the brain scans that I've already described. So monitoring for side effects and monitoring response to treatment are the key ways that we look after patients during with stage 4 disease during their treatment. So I just want to touch now on some of the side effects that we tend to see with these different, with the different more sort of modern treatment approaches. So first, with respect to targeted therapy side effects, so these are using these combination BRAF and MEK inhibitors, which are specific types of drugs. Actually, side effects of these drugs are pretty common. I'd say most patients usually get some sort of side effect, but often they're relatively mild. So things like fevers or rash or diarrhea, nausea and lethargy, tiredness are actually reasonably common, but often quite mild and really not that big a deal. Having said that, sometimes they can be a real problem. In fact, I saw a patient in my clinic today who's having terrible problems with fevers related to targeted therapies, and he's probably going to have to change to some other sort of treatment. And very, very occasionally, the fevers can be really out of control and make people extremely sick, even sometimes requiring going to intensive care. That's very unusual, but we all need to be alert for patients that that are really having bad fever reactions to the targeted therapies that we use. There are some very rare side effects, particularly from the use of the MEK inhibitors, such as the development of heart failure and also some eye problems. But in general, the vast majority of side effects that result from targeted therapies are actually reversible. Well, once you stop the drug, the side effects usually disappear and go away, or are certainly at least easily treatable. And so long-term side effects and the kind of monitoring management of these are actually virtually unheard of following the use of targeted therapies. And I think is one of the advantages of using these therapies, even in the sort of extra treatment after surgery context. So it's a bit of a different story for immunotherapy-associated side effects, which are very broad in their scope. If you kind of think about how immunotherapy works, it basically harnesses a person's sort of natural immune response against their cancer. Our immune systems generally are in this constant sort of state of balance, of readiness, of being sort of ready to act against a foreign invader, but also needing to be calmed down, and the immune system needs to be calm and settle down when there's no need to eliminate any foreign invaders anymore. And so it's this constant sort of tension between pushing the immune system to being overactive versus controlling it, but erring on the side of it being underactive. Immunotherapy generally as a concept kind of shifts that balance. It has a tendency to make the person's immunotherapy a little bit more overactive, and specifically and particularly for the anti-PD-1 drugs, does that in a way that is often, we think, quite specific to the attack of the immune system on the cancer cells. But because the person's immune system is just generally a little bit more pushed towards being overactive, sometimes it can get a bit confused and recognize normal tissues and normal organs as being bad things that it wants to attack and get rid of. And that's basically why immunotherapy causes side effects. And really, pretty much any tissue in the body can potentially be infected, can potentially be affected by immune attack induced by immunotherapy. For the anti-PD-1 drugs, in fact, although some level of side effects is actually reasonably common, they're actually, only infrequently severe and requiring of hospitalization or even some sort of antidote therapy. For the combination immunotherapy that I alluded to before, that we're increasingly using, the side effects are actually much more common, and when they do occur, often far more severe. And a reasonably high proportion of patients do need to come into hospital during a course of combination immunotherapy to have the particular side effect treated, often with some pretty strong immune suppressing medicine. But you can see the range of organs: liver, skin, the gut. Rarely the lungs, numerous hormone glands, rarely the brain, even the heart. So there's really quite a wide range of organs that can be affected by immunotherapy side effects. Albeit, most patients, if they get any side effect, they usually just get only one or maybe two of these. And often, as I said, for most patients, particularly those receiving just single agent PD-1 therapy, the side effects are relatively mild. So in fact, we don't always have to treat them, and we only really treat the side effects if they're bad enough to warrant treatment and really interfering with a person's quality of life, or potentially endangering their organs. I've said that they're more likely to occur as a consequence of combination immunotherapy, and generally the treatments for them involve temporarily suppressing a person's immune system to try and sort of dampen down that sort of overactivity that the immune system has given it. Although many of the side effects of immunotherapy are reversible, and in fact sometimes they just go away without any specific treatment, unfortunately there are some of the side effects that seem to be irreversible and that can cause long-term problems. And so there can be patients that are left with sort of chronic colitis, which is an inflammation of the gut causing tummy upsets and diarrhea, arthritis, which we all know causing joint pains, long-term kidney and nerve damage, sort of recurrent lung inflammation causing cough and breathing issues, and even things like diabetes requiring insulin, and some other long-term hormone system problems. So immunotherapy, can actually cause some pretty major damage to some organs that requires, really long-term management. And so for that reason, it's really important that we monitor for the development of immunotherapy side effects, which we do, as I've said before, via physicals and also blood tests, because we really think that detecting the onset of those side effects early versus late can actually be the difference between having a side effect that's relatively easily fixed versus one that requires hospitalization and potentially causes permanent damage. And as I said before, some side effects can even emerge after immunotherapy has been stopped. So in terms of managing those long-term side effects, I referred before to the problem of lymphedema, which is this swelling of an arm or leg after surgical removal of the nearby lymph glands. Really, the best way to manage this is to, as much as possible, prevent it. And so we recommend early referral to lymphedema services, which are associated with most of the major hospitals around the country. Problems of chronic colitis and arthritis are, not that uncommon. We typically involve the use of specialists in those areas, so gastroenterologists or rheumatologists, but there are sometimes patients that do need to go on various types of long-term medicines to actually suppress their immune systems. Kidney damage, in our experience, if it gets to a certain level, is best managed in collaboration with a kidney specialist, which is called a nephrologist, who will deal with things like managing blood pressure and other complicating issues around kidney damage. Nerve and brain damage is actually one of the hardest things. We typically involve our colleagues from the sort of brain and nerve area. They're called neurologists. But unfortunately, the effects of damage to nerves and brains, so they're very rare, but they can be very disabling. And brain and nerve tissue tends not to heal itself so well. So once the damage is done, often the recovery is not complete, and sometimes there's no recovery at all. There's a very specific type of localized brain damage, which is called radiation necrosis. This is intense inflammation in specific areas of the brain that have had tumors present in them, where those tumors have been treated with quite high doses of radiation therapy. And we think that it might be possibly made worse if patients also have immunotherapy, which increasingly, if they've got brain spots in the brain, then we actually give these days. And up to about 30% or so of patients can develop this sometimes challenging problem called radiation necrosis, that itself even requires sometimes more brain surgery to be able to treat. So there are certainly some challenges regarding long-term nerve and brain damage, albeit these are pretty uncommon. Lung inflammation can be really annoying because it can feel like it's kind of getting better and a person's are recovering, and then they've had some medicine to suppress their immune system, their lungs feel better, their breathing improves. You then get rid of the immunosuppression medicine, but then the lung inflammation comes back. And so these patients often require sort of repeated doses of this immunosuppressing medicine. And we often get involvement of lung specialists, which are called pulmonologists, to help us manage these particular patients. So finally, I said that probably the most common long-term problems that we have to manage are problems relating to damage to various hormone glands, most commonly affecting the thyroid gland, adrenal glands, pituitary, and also the pancreas, which can result in the loss of insulin production and cause diabetes. So these sort of long-term damaged glands typically require prolonged and often lifelong supplementation of the hormone that they've basically stopped producing. And some of the common ones that we use are thyroxine, cortisone, and I've mentioned insulin to treat the specific type of diabetes that we often see. So that's basically it, an overview of the way that we, treat stage 3 and 4 melanoma, what stage 3 and 4 melanoma is, but particularly the ways that we monitor patients, both for the development of side effects and also to see if the treatment's actually worked in terms of getting control of their stage 4 cancer, or in the case of Paige, which is an example of that's obviously shown on the screen here, or in the case of patients with stage 3 disease, hopefully preventing any recurrence of their cancer in the future. So thanks very much for your time. I'll stop talking there and very happy to take some questions.
Thank you so much, Professor Shackleton. That was absolutely incredible. Such an informative presentation. We do have a couple of questions. The first one that's coming from one of our patients is, why does there appear to be such a billing discrepancy for clients for diagnostic scans and imaging? And how do I access bulk billing? It's proving very expensive. So that was a question that came in. I'm not sure if you're able to respond to that one.
Yeah, I'm not sure what the specific discrepancy that's being referred to is. It might be, I work pretty much in the public hospital and academic health system, whereby, our hospital's policy is that patients pay for nothing. So every scan, every consultation that they have, every specialist they see, and every scan that they have is, you know, funded from the basically from public sources. Often private health providers, which are, you know, many of which are fantastic, of course, and which we really need and are important, often have sort of funding mixes where they will offset some of the costs of treatment that they provide in the manner that they provide it via bulk billing, but there are often gap fees or additional fees that are put on top of that, and that's just the way that the private system operates its particular business. If you don't want to pay any gaps or any excess fees and you want everything to be bulk billed, then you really got to go to the public system, where the vast majority of interactions between patients and the system won't be billed for.
Great advice, thank you, Professor Shackleton. There's one more question, and we must have some patients online who have uveal melanoma, and we're asking about treatment options for uveal melanoma. We potentially could have an entire webinar on that topic, I think.
We should. Yeah, so uveal melanoma is a particular, relatively uncommon type of melanoma that develops behind the eye. So it's not a classical skin melanoma at all. In fact, it's very different in many ways. Even genetically, there are really quite different mixes of genetic mutations that we see that are associated with the development of these rare uveal melanomas behind the eye. And they actually behave a little bit differently, even compared to skin melanomas. They've got this really, so most of them are actually managed by eye specialists. Occasionally, if they're big enough, unfortunately, they require complete removal of the affected eye, but that's not that common. And mostly they begin as very small spots at the back of the eye, and the eye specialist can sort of see them and locate where they are. And a treatment that's frequently applied is the application of what's called a radiation therapy plaque, where the plaque is basically attached to the tumor behind the eye, and they're often very, very good and effective ways of basically curing those. However, unfortunately, particularly for some genetic subtypes of uveal melanoma, they've got a pretty high tendency to want to spread and travel into the bloodstream and become stage 4 melanomas in the way that I described before. And they've got a very curious characteristic in that they really exclusively seem to spread to the liver, often bypassing every other organ. So they might be circulating in the bloodstream, but for some reason they don't have much interest in the vast majority of cases of actually sticking in any other organ apart from the liver. Of course, that's not a good thing, because the liver is a pretty important organ and it requires its own specialized treatment. I'll be honest with you, uveal melanoma historically has been one of the most difficult cancers to treat once it's spread to different parts of the body. It's almost one of the great challenges that we have in melanoma research at the moment, is to improve the range of effective therapies that we can use in patients that have got uveal melanoma that has already spread. But there's been some great breakthroughs in the last couple of years, and a really kind of paradigm-changing clinical trial that was announced earlier this year, in fact, of a new treatment called tebentafusp, which is only suitable for about 30 or 40% of people who've got a very specific type of immune system. But in those people, looks to be pretty effective and when given as an immunotherapy type treatment in actually controlling and substantially slowing the growth of and spread of uveal melanoma cells, even if they're pretty extensively through the liver. So there are now, or in many major centres around the country, people that are starting to be treated with tebentafusp, and the data from the clinical trial are actually quite compelling. So we finally have a drug that seems to be active against this disease, which is super exciting. And then on top of that, in part with my work through Mask Trials, we've actually formed a really dedicated national research group focused around that specific disease, and that's already resulted in several particularly pharmaceutical companies that have got some new and interesting potential anti-uveal melanoma drugs becoming really interested in coming over here and doing business in Australia to basically bring clinical trials of some of these new agents across to us, and we're really excited by the trajectory of some of that work.
Well, thank you so much, Professor Shackleton. I think we may have the topic for a further
Yes.
webinar down the track with very exciting, potential news for patients and their families in the uveal melanoma space. Well, on behalf of everyone at Melanoma Patients Australia, Professor Shackleton, thank you very much for your time this evening. I know you're incredibly busy out traveling in regional areas, conducting clinics, and you've taken a lot of time to speak with us tonight, and we are incredibly grateful. So thank you.
It's an absolute pleasure. And if there are additional questions that people want answered, maybe they can feed them through MPA, and you guys can forward them on to me.
Oh, that would be wonderful. Thank you. Really appreciate that.
Wonderful, guys. Good evening. Thank you very much for your attention. Cheers.
Thank you. We'll move now swiftly on to our final speaker, who's our patient speaker this evening, Leanne Lovegrove, who's been living with a diagnosis of melanoma for the past 33 years and has experienced several primary melanomas and a secondary melanoma during this time. This life experience has inspired Leanne to become a holistic counsellor, student of kinesiology and facilitator of change, assisting others to create their own happiness prescription for life. Blessed with a supportive husband and a beautiful daughter, Leanne lives in the gorgeous coastal town of Yeppoon in central Queensland and understands the great challenges of keeping sun safe and accessing professional medical services in a rural area. Very warm welcome, Leanne, and I would invite you to start your presentation.
Thanks, Victoria. Hi, everyone. My name's Leanne. I'd like to extend my sincere thanks to the MPA for inviting me to participate in this webinar. I'm very grateful to share my melanoma experience alongside the other guest speakers tonight. And I'm also grateful for everyone who's taken the time to watch this webinar, whether it's live or on replay. So I live in the coastal town of Yeppoon in central Queensland, and this land belongs to the traditional landowners, the Darumbal people. Yeppoon's located 45 kilometres from Rockhampton, where you can access the domestic airport, and it's 659 kilometres from our capital city, Brisbane, which is a very long 8-hour drive in a car. In this picture, you'll see my family. So I've been married to Simon for 22 years, and we have a beautiful daughter named Sienna, who's 13 years of age. As a holistic counsellor, I help people to facilitate change in their life. And I'm also a student of kinesiology and yoga. I use the term student because I don't feel like we ever stop learning as we grow in our life. I'm also very passionate about complementary therapies and in particular how our beliefs shape our experiences in life. So as a child, I lived in Rockhampton and I spent every single school holiday at the beach, where I enjoyed swimming and catching waves, as well as making loved heart-shaped sandcastles in the sand with my dad. Being a child of the 70s, wearing a hat or using sunscreen was not the done thing at the time, and it would be many years before the Slip Slop Slap campaign would be created to promote the importance of skin protection. I was fair-haired and fair-skinned with green eyes, and by adolescence I had a lot of dysplastic nevi moles. And this combination is now known to enhance the risk of melanoma, and it acts as a potential warning sign. In 1987, a mole on my left shoulder became itchy, and like any kid, I gave it a good scratch and it started to bleed. Over a period of 12 months, several doctors looked at this mole and reassured my mother and myself that it wasn't anything to worry about. Young people don't get skin cancer, and melanoma is an old person's disease. That mole continued to bleed, and eventually a doctor agreed to remove it in 1988, where at 12 years of age, I received a diagnosis of stage 2 melanoma. I had my first ever hospital stay to have surgery to widen the excision margins, and once stitched up, I was sent home with a large scar. The surgeon was confident that the melanoma had been fully removed and reassured me that everything was going to be fine. Now, at a time in your life when you're heavily influenced by your peers, I felt very angry about having this diagnosis and an ugly scar, as it made me feel different from everybody else. I now had to stay out of the sun when all my friends got to frolic in it. I had to wear greasy sunscreen and a hat, which was definitely not trendy at the time. And I also had to put up with comments from others about how gross that scar was on my shoulder. And I started to really hate my skin. Fast forward to 4 years, it's 1992, and I'm in year 12. And I've just found a lump just above my left collarbone, which I affectionately named Larry. I'm not sure why I decided to name it Larry, but at the time it seemed like a fun thing to do. And a trip to the doctor to show off Larry the lump resulted in me being referred to a local surgeon in Rockhampton to find out exactly what we're dealing with. And after the surgery, the pathologist diagnosed Larry the lump to be a lymph node that had been replaced with a 95% deposit of melanoma. The surgeon, he suspected that it had come from a primary melanoma that was excised 4 years prior, but clearly everything wasn't fine. I'm now 16 with a diagnosis of secondary melanoma, and in a flash, I find myself lying in the surgical ward of the Princess Alexandra Hospital, surrounded by old people. The surgery to remove 12 additional lymph nodes was performed by Professor Rodney McLeod and Professor Mark Smithers, who at the time was a registrar. And I distinctly remember the compassion Mark extended to me each day on his hospital rounds, when I would continually ask him the same question of when can I go home? And he would always smile and reassure me that it'd be one day soon. I remember those lonely nights in hospital, feeling so sad, as during the day I was doing my best to keep smiling as to not to upset my mum. However, on the inside, I felt that life just isn't fair. You know, it was during those late night ponderings that something shifted in my thinking. And instead of thinking and dwelling on, well, why me? I asked myself the question, well, why not me? I couldn't come up with one single person that I would wish this diagnosis on. And I decided that I needed to accept what was happening and do my best to focus on the positive. From memory, I don't think anyone really knew what the prognosis was going to be for me. It was said I'd be lucky to make my 18th birthday, as at the time there wasn't any treatment for advanced melanoma, such as targeted therapies and immunotherapies that we have today. I was sent home to Rockhampton and required to attend the melanoma clinic at the Princess Alexandra Hospital every 3 months and have regular lung x-rays and blood tests for the next 2 years in a wait and watch exercise. So every 3 months, Mum and I hopped on a train to Brisbane for these checkups, as the cost of flying to Brisbane was ridiculously expensive. And after a few years, the time between checkups was extended to 6 months, and I eventually started seeing a private dermatologist in Brisbane who took over the monitoring of my skin. A 6-monthly date with my dermatologist is an expensive exercise. For me, a skin check involves driving to Rockhampton, leaving my car in paid airport parking, a return flight to Brisbane, at least one night's accommodation, several trips on public transport, as well as the consultation and biopsy fees. And for all the appointments I've had with my dermatologist, there's always something that needs to have a scraping done and a pathology report. Every few years, I also have medical photos taken of my skin to help me track any changes and also for my dermatologist to refer to during our appointments. So it's fair to say I don't have a holiday savings account. I have a medical checkup savings account. I like to look at the expense of my skin checkups as an investment, as I can say hand on my heart, one of the main reasons that I'm still alive and able to speak with you is because of those 6 monthly checkups with my much loved dermatologist. Early detection really is the key to surviving melanoma. So along with the expense of regular skin checkups, there's also that frequent visitor of anxiety. that internal dialogue of what if the doctor finds something, or what if it's back, or what if I have to have surgery, you know, runs like a tape loop in your mind. And it can be really difficult for your family and friends to truly understand, as their comments of, you know, you'll be right, or just don't think about it, it really doesn't make you feel any better. I've learned some great techniques that help me to dissolve my anxiety and allow me to feel good about attending my checkups. I now have an inner knowing that I can handle any outcome those checkups may deliver. So in Queensland, it is worth looking into the Queensland Health Patient Travel Subsidy Scheme, which can offer a subsidy to help with attending medical appointments away from your home. That's if you meet their criteria. You can also access medical imaging available through mole mapping or vector machines and clinical medical photographs, with the majority of these services being offered in your capital city. So in 2019, I was approached by the Melanoma March organisers in Rockhampton to share my melanoma story at their upcoming march, which is in support of the Melanoma Institute Australia to raise awareness and much needed research funds to continue their mission of 0 deaths from melanoma. Up until this time, I had kept my melanoma history private, as it saved me the pain of dredging up the past and all those emotions that I had bundled up and squashed deep down inside. It also prevented me from hearing people's flippant comments of, it's no big deal, it's just skin cancer, you know, get over it. But I found participating with the Melanoma March, it really helped me realise that I was not alone on this melanoma journey, and that there were other people just like me with similar experiences. There were also a lot of unprocessed emotions relating to my childhood experiences with melanoma, which had me in tears on several occasions during the march. I was really taken back from witnessing the amazing support, you know, family, friends, and the community provided to those diagnosed with melanoma. And I do encourage you to participate where you can in a melanoma march. It was during 2019, I received the diagnosis of 2 level 1 melanomas in the space of 6 months. It was ironic, as one of those melanomas was diagnosed at the time of the Melanoma March, where I was advocating for melanoma awareness. Now, I guess life has a sense of humour at times. But I certainly wasn't laughing. I felt very angry and so frustrated, and I really was questioning where the justice was, as I felt like I was doing everything right, everything that was requested of me. I've stayed out of the sun for years, reduced my social activities outdoor, you know, often missing out on events with friends to the point they stopped asking me to join them. I wear the sun-safe clothing, I wear sunscreen, and I have my regular skin checks, but melanoma just won't leave me alone. I also felt a great sadness at that diagnosis, as the realization came crashing down that melanoma wasn't something that lived in my past. I now realize that it also lives in the present, and in some form would be in my future as well. This realization has taken me to a whole new level of acceptance and gratitude for my life. And I've also discovered that volunteering with the MPA has helped me make something good out of my life with melanoma. So to date, I have had the grand total of 6 primary melanomas and 1 secondary melanoma. And yes, it seems like melanoma likes me a little bit too much. With each melanoma diagnosis I've received comes a big tub of chocolate ice cream and a 24-hour pity party as I process the news and prepare myself for more surgery. I have lost count of the number of surgeries and scars that I have, and while some people see plastic surgeons for cosmetic reasons, I get to see them for reconstructive purposes. The majority of my melanomas have been stage 1, which are easily treatable with surgery, and they have mostly been detected by myself, which really highlights the importance of knowing your skin. By being familiar with your skin, you can identify quickly if a mole is new or has changed and take immediate action by seeing a doctor. Unfortunately, there are times when going to a doctor isn't enough, and I have had experiences where doctors have told me not to worry about a mole, and it was only from my persistence to have a biopsy that a melanoma was diagnosed. And sadly, I've spoken to so many people who share a similar story. However, they thought the doctor knew best, and melanomas went undetected until it was too late. Please know that doctors are amazing people and I have great respect for them. However, they are also human beings who can occasionally make mistakes. I encourage you to trust your intuition. There are just times where you have a gut feeling that something isn't right and your inner alarm bell goes off. And when this happens, I just urge you to take action. Request a biopsy from your doctor or ask for a referral to a dermatologist. So as I learned to embrace my melanoma journey, gone are the days where I get to wear a bikini to the beach. Instead, I'm covered head to toe, doing my best to protect myself and reduce the risk of further melanomas. And sure, there are times when I think, why bother? It does not seem to make a difference anyway. However, I just take one look at my daughter and I know that I want to live the longest life that I can with her. And that is my very reason for looking after my skin. I'm also from a family of 5, which I wanted to share with you. I have an older brother and a sister. And believe it or not, there's 6 people in this photograph who have had melanoma, including my brother-in-law. So I ask you to keep an eye on your loved ones. And if you see something, please say something. If it's on your skin, say something to your doctor. If it's on someone else's, say something to them. You may just save your life, a life of a loved one, or a life of a complete stranger. In closing, I would like to share with you an analogy for the word hope. I truly believe that having hope means to have only positive expectations. So wherever you are on your melanoma journey, please have hope. Have only positive expectations for each day. If you'd like to get in touch with me or find out more information about the services I offer, you can find my website at thehappinessprescription.com. I'm here to help and I'm always happy to have a chat both online and in person. Thank you for your time.
Wow, Leanne, thank you so much for sharing your powerful and insightful story. And what a long journey, 33 years of melanoma activity and having to do those trips down to Brisbane. Just incredible. I know that by sharing your story, it gives hope and inspiration to others going through similar issues. And I'm sure many here tonight will appreciate the impact melanoma has had on your life over a very long period of time. On behalf of everyone at Melanoma Patients Australia, this completes our session tonight. Thank you so much for joining us. And thank you very much to all of our speakers who've done an incredible job. I encourage you to watch out for our new Wellness Hub, and all of the resources in our Wellness webinar series will be uploaded to that Wellness Hub shortly. Thanks again to our sponsors for this evening, MSD. They've supported us in this webinar series and our Wellness Hub activities. Thank you once again to everybody who's gone behind the scenes in organising our event this evening, and to all our speakers, patients, carers and their family members, wherever they are in Australia. Good night, everyone, and thank you for being part of this incredible journey.